Next presenter, Dr. Chitralekha. Is she here?
Good afternoon, everyone, and thank you for this opportunity to discuss a very interesting case. This is a case of a 4-day-old term neonate admitted in the NICU with coagulopathy, thrombocytopenia, meconium aspiration syndrome, pulmonary hypertension, and hyperinsulinemic hypoglycemia. The child was referred to the ophthalmology department because a very observant resident in the NICU noted an abnormal red reflex in the left eye of the baby. So on day 4, when we examined the baby, the anterior segment examination was unremarkable and the fundus had these features. As we can see, this is the right eye showing proliferative retinopathy with vascular loops at the optic disc and looping of the peripheral vessels along with avascular retina in the periphery. So these images have been captured with the Zeiss handheld camera. So we can only capture 40° of the fundus. So this is the left eye. This had vitreous hemorrhage, and this was the red reflex noted by the resident. The vitreous hemorrhage was seen nasally and over the optic disc, while the peripheral temporal retina was visible and vascular loops were there, but that is again not captured in the fundus image. So this child then underwent a platelet transfusion on day 8 of life, and we did laser photocoagulation to all the avascular area in the right eye. So post-laser, this is again 3 to 4 weeks post-laser in the right eye. We can see the laser area in the periphery and the complete resolution of the proliferation in the posterior pole. The left eye, because of the presence of vitreous hemorrhage, the laser was only partially possible in the temporal retina, again after the platelet transfusion. On follow-up, there was increase in vitreous hemorrhage. Then intravitreal ranibizumab was administered after the control of coagulopathy. However, the vitreous hemorrhage continued to persist. This child then went on to undergo an LSB under GA in view of the persistent vitreous hemorrhage. And when the surgery was being done, tractional RD was noted nasally. Post-operatively too, we can see these are the post-operative photos on follow-up, that there is a nasal dry retinal fold. However, the rest of the retina is stabilized and the macula is fine. So basically, this is a case of a full-term baby having proliferative retinopathy. So most likely a case of FEVR. Why we are seeing most likely? Because we did not do a genetic workup. So as we all know, FEVR is a dysfunctional retinal angiogenesis resulting in avascular peripheral retina with resultant neovascularization and its subsequent sequelae. Commonly seen in full-term children, however, sometimes they can overlap an ROP in a preterm when we call it ROPER. So a positive family history helps in the diagnosis. However, a negative family history does not negate the presence of FEVR. They are genetically heterogeneous, and even the phenotypic presentation varies a lot from asymptomatic peripheral retinas to tractional RDs causing severe sight loss. So the conclusion is that FEVR, we should bear in mind that FEVR is an important cause of sight loss in full-term infants, and infants with multiple comorbidities admitted in the NICU should preferably undergo an ophthalmic examination early on in life. A multidisciplinary team approach, which actually helped in this child's case, with the presence of an alert neonatology team, is extremely important because the mean age of presentation with visual defects for a child with FEVR is around 4.5 to 5 years. And also FEVR, another take-home point is that FEVR has a persistent course. So we need to make sure that the child is followed up, unlike ROP. Thank you.
But if you are diagnosing it as FEVR, do you suggest anti-VEGF?
So ideally it should only be lasered in FEVR, but because of the persistent vitreous hemorrhage and the unstable clinical status of the child at that time who couldn't undergo a surgery, so that is why we injected. Yes, actually a very important question.
Ma'am, one thing that usually we in ROP we ask after 4 weeks.
Yes,
But
yes.
in this case,
This
it
is
isn't.
just, I would say the child was blessed and they noted a red reflex because of their existing hemorrhage. So it was not part of our usual ROP screening. It was like an emergency call, there's a red reflex, and so the child was lucky and the team was observant.
What do you suggest? How, at what time should we, with a child with
No,
a
if we have a-
multiple comorbidities?
Huh.
If
So again, I think similar to ROP at 3 weeks, but if somebody has a coagulopathy, then maybe earlier because they may even have vitreous hemorrhage without the presence of a proliferative retinopathy.
Thank you.